Are there certain triptans then that are better than others, or how does someone determine which one to take besides availability? One of our viewers Judy shared that her neurologist prescribed naratriptan because it has fewer side effects than eletriptan, but it takes longer to work.
She's right, yeah. Well, the first thing that I want to say is that, we could first probably even describe each of the triptans, but I can see that you are all already very much, educated on how many triptans we have, what are their formulations, their doses. For example, I was thinking on differences. In Spain, we have the availability of eletriptan, so one of them, only in the 20 and 40 milligram dose. And instead, I think that in the United States, you have the 80 milligram dose. So that's another added difference that you might find country per country. In regards specifically to your question, there has not been like a true, you would say, we call them phase 3, so true clinical trial to compare triptans amongst themselves. So one versus the other one. So we cannot say that one is really better, I would say, or how really different sometimes they are. So the only way they have been compared amongst each other is through indirect statistical analysis. There are statistical ways of doing this. We call them, there's different ones, but meta-analysis or systematic review meta-analysis. There's different ways of comparing drugs indirectly. Usually you use the data that comes from the phase 3 trials, we call them, so the randomized clinical trials. And these trials, even if in the headache guidelines, in the International Headache Society guidelines, where there are kind of the rules of how trials should be done to prove that the drug that you are testing against placebo is better than placebo, every trial then has certain little differences that are sometimes, hard to make them exactly comparable when you have, the results. What do we really know scientifically? That all of these triptans that are already in the market are better than placebo. And the primary endpoint, so what we ask of the drug is the percentage of persons who use the treatment that are pain or symptom-free after 2 hours. That's usually the first primary endpoint, or at least functionally much better, that can return to function. And so there's different, as I say, even ways of measuring. You can decide, and you do this a priori. So before starting the trial, you decide which outcome is going to be your main outcome, and it can be pain freedom at 2 hours. It can be reduction in pain after 2 hours. But there are also some secondary outcomes that you look into, which are how the other symptoms of the attack are reduced. So bothersome symptoms such as nausea or photophobia or aura. And then we look into also the sustainability of this response, whether if it lasts 24 hours or if there is a recurrence of pain or other symptoms within those 24 to 48 hours. So this is how trials are designed. And within that, there are mild differences amongst the trials. But there are systematic ways of trying to compare these drugs that have data out there to see how are they different. And already in 2001, there was this, I would say nowadays, very well-known paper that was published comparing, so meta-analyzing all of the triptans that had been launched at that time. For example, frovatriptan was not included in that analysis because it was not yet launched. But we did realize that it seemed that there were certain triptans that seemed to work a bit, so in the percentage of responders, seemed to work a bit faster. Others that perhaps were better tolerated, so less adverse events or effects were noted, in the trial. Others that had greater or lesser recurrence. Others that perhaps were slower at the beginning, at least according to these numbers. And others that were a bit, quicker, so slower versus quick, so the speed of onset of action. And all of that created knowledge around these differences that we have adopted